Welcome.
Thank you. So I have 20 minutes, well, less actually. Myself and Gure have 20 minutes to summarize what happened over conferences, many conferences. I think I will just give you a really small taste. It will be a really hard feat. But first, IAS conference was held, where was the IAS conference? The AIDS conference in Munich, in Germany. So just highlight a few things. One is we got to hear about another patient who has been cured from HIV. It was called the Next Berlin patient. This was the 7th patient cured of HIV, and they also received stem cell transplants. What is unique about this patient is that the ones in the past had been treated or cured because they received transplants from donors who had what is called a Delta 5, CCR Delta 5 mutation, so that those people could not have receptors that would for CCR5, and so those people could not get HIV. Those were the previous cured people. This particular one received the person who donated was CCR5 heterozygous, meaning one gene could not make CCR5, but one gene could. This is unlike the previous, who both genes could not make CCR5. And so why this is important is that perhaps for future cure strategies, we do not need to eliminate all CCR5 receptors to be able to manage. Perhaps that's what this is telling us, but it was a very interesting situation and very interesting case to be presented. And what we have there are the 3 other people who have also been cured of HIV so far, who are at the meeting. And then they also talked about approaches to cure HIV. A lot of work was around discussions about what is advancing forward in approaches of curing HIV, includes using broadly neutralizing antibodies, but also there was something about genetic engineering, getting into the cells, pro-viral DNA, and trying to pull out HIV DNA that it's incorporated. It was presented, was only about 6 participants, was found to be safe, but it's still very early, and I think a lot of work, or a lot more work needs to be looked at to assess the safety of editing the genetic makeup. And then some work around transcription inhibition, which is different from how we do HIV treatment. There was sharing about HIV vaccines and different ways in which we are trying to get to develop a vaccine. We are still very far away from developing a vaccine. It looks like we are no nearer than we were 10 years ago, but we have a lot more knowledge, experience, and tools to accelerate development of the vaccine, and we hope we're going to get there sooner now than before. So that's about cure vaccines, but then related to our work here, we're going to have a session about non-communicable diseases, and I wanted to share this presentation that was made by people from Zambia, in which they had a package that was a one-stop shop for NCDs and HIV integration. So within a clinic, you do have, you integrate NCD and HIV care, implement WHO protocols for NCDs, set up algorithms, train providers, and then in their medical records incorporate HIV care and also follow up for NCDs, and then strengthened the medication supply for clients who had both NCDs and were receiving HIV care in their clinics, and then implemented task shifting and task sharing also within those clinics. And what they wanted to see is whether we would get dual control of both HIV and their NCD, specifically blood pressure. And so in these clinics, they enrolled about close to 200 participants. The cohort was about 70% female. And what we found, if you compare the baseline, I don't know if this, or maybe it has no, if you compare baseline and the follow-up proportions, you do find that compared to baseline, at follow-up, people had much better blood pressure control, had much better HIV control, but importantly is even just control of both, that an individual is able to control both their HIV and their blood pressure when you have integrated services being implemented in a clinic. So that may be important for us as we move forward. I think the big thing that you probably have had was first presented at the meeting in Munich is this trial, the Purpose 1 trial. This was a randomized clinical trial that was evaluating 3 PrEP options, and one of the options is lenacapavir. Lenacapavir is a novel capsid inhibitor, has a long half-life. It is given subcutaneously and is given every 6 months. In this trial, they recruited up to 5,000 women, and the thing was we wanted to find out whether this product, lenacapavir, is safe and effective at preventing HIV infection. And so women came in for enrollment, and they were screened whether they were HIV positive or negative and eligible into the study. If they were HIV positive, then they did recent assays to determine how far away they got infection and used that information to determine background incidence. For those who were negative and were eligible to enroll in the study were then randomized to either receive the lenacapavir injection, oral PrEP, TDF-FTC, or another oral option instead of TDF is called TAF, which had not been tested in women prior to this. So it was a study of 3 arms. Every participant in the study either got an oral pill or an injection. You're either getting oral placebo or oral active product, or an injection placebo or injection lenacapavir. So you wouldn't know who was using which product. So median age of participants was about 21. The studies were done in South Africa and Uganda, so almost everyone was Black, and very many of them were single. They enrolled a population that was highly vulnerable to HIV acquisition. About 1/3 of them tested positive for STIs. That's just a big number, don't you think? Of all these women coming into clinic, so many of them have STIs, and most of those are asymptomatic even, and they have been in our care, and probably we haven't even picked it out. And then the background incidence was high, was 2.4 per 100 person years. So what did we find? What did they find? 55 participants acquired HIV out of all those enrolled, but zero in the lenacapavir arm. That's the number I want you to remember. For women who enrolled in that study, who received subcutaneous injection, there was 0 new infections. So 100% efficacy compared to background incidence and 100% efficacy compared to oral TDF. Between the product TAF and TDF, there was no significant difference in efficacy between those 2 arms. What do we know about adherence? Adherence was high for injections. 90% of the injections were given on time. But oral PrEP adherence was poor. Look at the dark green or the green bars, and you can see at week 8 for both TAF and TDF, you have about 50% for TAF, and by the time you're reaching to the end of the study, very few people are actually adhering to product. And the same is true of the TDF arm, the green. So poor adherence seems to explain the poor results for those on oral PrEP. But those who are adherent to oral PrEP were protected. What did we find? The products were safe and well tolerated. The injection was safe and well tolerated, very few side effects. Most people did have nodules, which is, when you get a subcutaneous injection, you come back, you will feel a nodule, a lump under your skin. It was harmless, usually invisible, but that was the most common side effect. Participants in this study were allowed to get pregnant, and so for the first time in a randomized clinical control trial of PrEP, we do have data, safety data, for pregnant and breastfeeding women. So we don't have to wait much later to say we are waiting for safety data for pregnant women. As reviews are happening, we will have reviews for data for pregnant women. At the same time that study was happening, then there was another study, similar study happening for MSM and transgender women in South America and in the US. In that study as well, they enrolled 2,000 people. There were 2 infections in the lenacapavir arm compared to what they found in the oral TDF arm, which was 9 infections. So again here, lenacapavir in this population was highly effective in preventing HIV infection compared to oral PrEP and compared to background incidence by over 90%. So this product is safe and effective for both men and women at very high efficacy levels, higher than what we have for oral PrEP. So in summary, I will not summarize this because of time, but what is important, by the time we are preparing these slides, it was saying that FDA is reviewing lenacapavir data in 2025, and we are waiting a review. So we just found out last night that FDA has provided approval for lenacapavir, and we are all really excited about this. I'm handing over to Nguria to continue.
Thank you, Elizabeth, and for setting pace and the excitement on lenacapavir. Lenacapavir, by last year, was voted as the breakthrough of 2024. It was the biggest. Most of us have been working on HIV prevention, and it was our first time to see a tool that conferred 100% protection. And now with FDA approving, which made us very excited, I think many of us were just emailing each other last night, we were now, it opens doors to see WHO giving guidelines, and they have already developed guidelines that will be launched next month at the IAS meeting. So it's a very exciting time. If you forget anything else we say, remember lenacapavir, because it's a potential game changer. It's a potential game changer in HIV prevention. So there were many studies that were presented in CROI. I'm only giving you a flavor, but the website has all the resources. And my flavor will mainly focus on HIV prevention. So as you've heard from Dr. Elizabeth, is that lenacapavir was being given as a sub-acute injection and was working for 6 months. But investigators went on to see whether if you gave it intramuscularly, that's an IM injection, whether you'd be able to achieve a longer duration. And there's promising results that you could actually use lenacapavir IM for 1 year. So you go to the clinic every year. What does that portend? It makes it so easy. Now with the threatened funding issues, it's a less burden on health services. It's less burden on individuals. So stay tuned, because this is very promising that you could now be able to get lenacapavir once a year. Again, staying on the theme of lenacapavir and Purpose 1 studies, this was the excitement that was both created at the L4P conference and the IAS that continued to CROI, because again, this was the news of the year in 2024. We all believe, and it has been said earlier, that adolescent girls and young women, especially in sub-Saharan Africa, including in Mozambique, are the highest risk of HIV infection. But even being at the highest risk of HIV infection, what we are able to observe is that they also do not adhere to PrEP very well. They have the biggest challenges in adhering to PrEP. And so it's important to find out whether lenacapavir injectable would work for them. And what was found that, one, it's that it's safe. Secondly, is that it is also efficacious and was able to achieve the same drug levels, PK levels, as women aged 18 to 25. This is important because the earlier PrEP trials were showing that young women were not achieving, there was no efficacy among young women, adolescent girls and young women. But it was not that the products were not working, it was all related to adherence. So this product showing that it is safe, it's efficacious, is a potential tool that could be used by these women who are at the highest risk of HIV. Then, as Dr. Inongo said, is about the TAF. FTAF was being tested for the first time in women, and we're also able to see high number of infections. Remember, lenacapavir arm had 0 infections. In the FTAF arm, there were 37 infections. But what was able to be shown is that out of those 37, 35 of them had suboptimal adherence, meaning that FTAF is also an additional tool, but a tool that only works when used. There's some potentially additional exciting news. We know adhering to daily pills is a challenge for many people. There is this pill that has been developed. It has no name yet. It's been developed by Merck. It's known as MK8527, and this is a monthly pill. Think about what a monthly pill could be able to do when taken just on the health services and just being used once a month. It has a new technology known as NRTTI. For those who had heard about a drug known as islatravir, it's the same kind of mechanism. And this has already been tested in phase 1, and now getting into phase 2 and phase 3s, and they're looking at various doses. And so stay tuned for this. But initial thoughts are able to show that when you use, for example, even a 6 milligram dose, you are able to achieve protection levels for 90% of the population. So it's very promising. So the prevention toolbox is expanding with injectables, monthly pills. And what I also want to mention here is as the field of prevention is progressing, there are also studies that have been presented in both IAS and both CROI that are also showing that the field of treatment is also moving forward. So we are also having pills that could be used per week, and they are combining. For treatment, you don't use one therapy. So like they are combining islatravir and cabotegravir for a weekly pill. So there are a lot of fancy combinations, and I would encourage the clinicians in the audience to look at those studies. Again, going on the theme of adherence and issues of risk, many people are not at risk continuously. It's a season of risk. And that has affected adherence, especially for those who consider themselves to be single. And that's why one of the studies known as IPAGAME was able to show that if you take 2 pills, 2 to 24 hours before sex, and then a pill after 24 hours, another pill now after 48 hours, you are able to achieve more than 80% protection for the 7 days. And meaning that this is what you call on-demand PrEP. There are other modelers that have looked on both pharmacokinetics and pharmacodynamic studies to look at various models. Some of them are looking at taking 2 pills a day for 4 days to achieve 7-day protection with about 95% protection. Exciting, but 2 pills could also border safety issues. And then you have looked at, there are others that have looked at 2-1-1. And all these studies, what they're showing is that working with 2 pills around time of sex, and then 1 pill for 3 days, so that's up to 72 hours, could offer sufficient protection of about 80%. And this opens a door for this exploration among cisgender women or among women. So meaning this is another exciting field that we will soon have another option for women where you can take this regimen around the time of sex or on demand. So then, when we have all these tools, what happens about preferences? So we are excited that lenacapavir is there. But is it going to work for everyone? Is everybody going to be excited about an injection? Not exactly. Even within Purpose 1, among these over 5,000 women, what was able to be shown is 2/3 preferred the injections. So what happens to the 1/3? 1/3 prefer other things, including the orals. So what we are calling for in the field of prevention is choice. Let's be excited about the new products, but offer them in the context of choice like we have in the field of contraception. And the same thing was corroborated within the qualitative studies that were done among 108 women that showed that injectables were highly preferred, but not all women preferred the injectables. And the reasons for this acceptance and preference is that it is easier, you don't need to have daily adherence, there's reduced stigma. Stigma is a big thing, as again we had earlier, when it comes to treatment and prevention, because people will carry pills, they'll be thought to be HIV infected, they have no place to store, especially if they are shared accommodation or they are young women. So again, that's why injections are preferred by a majority, but not everyone. So as we continue thinking about expanding the prevention toolbox, let's know that we have a very exciting product It's going to be subject to funding, so let's continue advocating for funding. And as we do that, we just think that even the older products will need to be provided in the same context. So we'll thank you, and we'll be open for questions at a later time.